oh, darn it, they didn't lose weight. Think about it. In many of our patients, weight maintenance is the goal. Because what happens every year if we do nothing? Most people gain that 2 to 3 pounds over the holidays that they swear they're going to exercise off in January, that they never do. So gaining 2 to 3 pounds a year is what happens to most people. So even weight maintenance in this study was important. And that's because of the additional touches that they had. You saw that the green line, the lifestyle people lost the most weight overall, and it stayed up to the 4 years of DPP. They still had lower weights than everyone else, but after that, and then during the boost periods, and thereafter, the metformin and the lifestyle have paralleled each other exactly. I gotta tell you, being involved in the study has been very humbling. I would have sworn my life that no, lifestyle will always trump it, it'll be fine, we'll be able to maintain it. And it is hard as heck. And we still are touching them a lot. We're still trying a lot. But I can tell you, they absolutely have paralleled metformin now we're 13 years out now, that exactly parallel. The interesting thing about metformin is over time it looks better and better. People lose that weight on metformin, and if they adhere to the metformin, the weight stays off.
Carol, back to that slide. For those who are in the lifestyle group, did you track whether or not at 6 years they were still keeping that 150 minutes?
So, yeah, we did. We have tracked it here. So their adherence to lifestyle drifted downward over time, but it was always better than in the placebo group. It stayed better. And that's what happens to all our patients. We were still having our every 3 to 4 month sessions. We're still engaging them, but that's what happens over time.
Question also?
Yes.
In those extended years,
yes,
did you still provide the same things you did in the first 5 years for them as far as the funding for the program?
That's a great question. Yes, we did. What we did back off on was the frequency of touches because of a pure funding issue.
Okay.
So we were not touching them as often. So I think that had a lot to do with some of the upward drift.
Mm-hmm.
But we were still touching them, just not monthly anymore, like every 3 months. But weight loss is really hard to sustain. And I take that, I learned in medical school, as long as calories in, calories out, that's all. It's not that easy. It's just not that easy at all.
Add in hormones and you might have a better equation.
Well, there's so many things. I mean, I don't want to disparage any dietitians, but everything we were taught was a little bit wrong.
Yes.
A calories a calorie. No, it's not. Actually, there's different metabolic consequences of different calories. Doesn't matter what time of day you eat as long as you have the same calories. No, of course it matters. It matters that whether, I don't know. So a lot of the things that, it's very humbling. This has been a very humbling experience. So the key findings about predicting weight loss, so improvements in diet, calories and fat grams, percent of calories from fat, and number of total calories overall. Diet. What you eat was by far the most important in predicting what weight you lost. And it's funny, you have all these TV shows like The Biggest Loser that tell people, as long as you get on that treadmill, yeah, no, that's not how it works. It can help, but it's really all about what you eat. The physical activity, though, became a much stronger predictor of maintenance of weight loss. So years out, it's the people who still were doing that 150 minutes a week or even upping it that had the most success. And what we found was that an increase in every 5 metabolic hours per week of activity would result in a 0.43 kilogram weight loss. So that's about 1 hour of walking a week. It's not, and the reason we so liked walking is because everyone could do it. No equipment, no gym you need, and you can go to the mall if your neighborhood's not safe enough. So we were able to get everybody to walk. So weight loss was largely determined by changes in diet and a little bit exercise. It's a primary factor resulting in reduced diabetes. And of course, physical activity is what's important in sustaining weight loss, and it independently reduced diabetes risk among those who did lose weight. So even in people whose weight did not go down, the more physical activity they did, the lower their risk of developing diabetes. But exercise alone, never, it says rarely here, but the answer is it never resulted in weight loss. So we know that interventions to reduce the incidence of diabetes really should aim at weight loss as the primary determinant of success. It's going to be via diet for most people. So dietary changes are essential for weight loss. Regular physical activity is essential for weight maintenance. Okay, so remember this intervention again that I was talking about. And it took a lot of work to do it. I told you all about how we did it. But that was another key lesson, just regular contact, touches after touches after touches. And that's why when Medicare says we'll pay for weight loss counseling and they give you like 6 sessions and then they're done, I'm like, that's never gonna work. You have to keep touching them. Okay, the other good thing was that when you prevent diabetes, you improve everything. So you can see the changes in blood pressure in the DPP. The green is the lifestyle, blue is metformin, black is placebo. Both systolic and diastolic blood pressure went down the most with lifestyle, and it turns out even with less drug. So the blood pressures were lower and they used less medications to do it. Total cholesterol and LDL cholesterol went down the most in the people who are on lifestyle. So green, the total cholesterol went down the most. Interestingly, LDL cholesterol went down the most in the placebo arm, but they also had the most people converted to diabetes, so more of them were on statins. So triglycerides went the most down in the lifestyle group. HDL went up the most in the lifestyle group. So really all the cardiovascular risk factors got better in people who are on lifestyle. They had lower percent of people on antihypertensive medications, lipid-lowering agents, blood pressure was better, serum cholesterol was better, and triglycerides were better. So prevention of diabetes is associated with improvement in almost all of cardiovascular risk. Actually, I will say all. Well, I don't know, it probably doesn't stop people from smoking, maybe it does, but most risk factors. Since they've been involved in this study, all of the people have decreased their blood pressure, cholesterol, and triglycerides. Lifestyle has done it the most, and they've done it the most with the least amount of medication. So it's kind of a win-win. They can get lower blood pressures, use less medications, and that's why healthcare costs in that group went down. Again, going back to the weight, placebo maintained their weight. And again, we were like, a lot of our patients, we were like, oh, good for you, you didn't gain any weight. That's a laudable thing. But the metformin and the lifestyle group have completely merged in their weight loss. And when you look at the weight loss by age group, this is what you saw. If you were young, you actually, the colors have changed, and I apologize for that. But the placebo group actually kept gaining weight. Remember, in the overall, there was no change at all. But for the youngest cohort, it's 25 to 44, the placebo group actually gained weight, while the metformin group, that's yellow, actually got back to baseline, and the lifestyle group paralleled them as well. So young people actually gained more weight than the older people in the study. So those are the youngest. These are the middle-aged people. So in the placebo arm, they drove the whole overall outcome. They did not gain weight in the placebo group. That's good. And the blue bar, which is lifestyle now, they had the greatest weight loss. That came back up in parallel metformin, the yellow bar throughout. So the middle-aged group, the greatest number of participants in the study are middle-aged, so they sort of drove the response of the whole cohort. Now in the older group, it was interesting. So after about age 65, we all just happen to start losing weight. I don't know if that's because the metabolic demands of just keeping us alive or so much more, but people naturally start losing weight after the age of 65. And that's what we saw in this study as well. So if you look at the placebo group, again, that's the green line now, they started to lose weight at about 4 years and then just kept going down. The metformin group has done the same thing, lost weight the initial 4 years and has kept going down. And the lifestyle group lost the initial greatest amount of weight, but now have drifted up. So right now in the older age groups, they look the exact same in terms of weight. So after 60 years of age, people tend to begin to lose weight.
Is that because of loss of muscle mass?
It probably has something to do with loss of muscle mass, but probably just the basal metabolic rate of just keeping us alive is what probably takes a little bit more. And we do lose muscle mass, so. But what was interesting, if you look at the oldest age group here, the over 60, it didn't really matter. Remember, they're the ones who, after 60, the weight was exactly the same between placebo, metformin, and lifestyle, but they still, by being involved in lifestyle, still had a significantly lower rate of progression to diabetes. So that tells me that it's not, especially, I don't know, I spent a lot of time trying to think about this. So it's not just, it's weight loss overall, really controls everything, but in the older age group, there's something about being active or losing weight that, or at least trying to watch calories that lowers their risk, but it didn't have to result in weight loss. So lifestyle appears to have the greatest impact on older patients, so this showed you, but it's possibly due to greater weight loss, but as I showed you, by the time we got to 10 years out, the weight was exactly the same between placebo, metformin, and lifestyle in the oldest age group. Okay, so now the age-old question, what's more important than our genes or our environment? Some people are like, I can't help it if I get diabetes or overweight, it's in my genes, there's nothing I can do. Well, in this study, this is, I'm sorry, very busy slide, but there's a number of common genetic variants that have been associated with development of diabetes, but we found that in the DPP participants that had the TT genotype, that's the genotype that's associated with development of diabetes. So they're more likely to get diabetes than those who had the CC genotype. And those who had one of each of TC were intermediate. But we found that both metformin and lifestyle could mitigate that risk. So in other words, if you had the bad genotype TT, you could reduce your chances of developing diabetes with lifestyle or with metformin as compared to those who had TT but were on placebo. So it's not like genes are not your destiny always. You can moderate it a little bit by lifestyle. So this is exactly what it shows. So these are the CC. CC is the good genotype. You can see that on no matter what, whether you're placebo, metformin, or lifestyle, the CC genotype has the lowest rate of developing diabetes. The TT is the worst genotype, and no matter what you're on, they have the highest rates, except if you're on lifestyle. And the TT, the bad genes, had the exact same rate of developing diabetes as did the.
Do you know what that genotype is actually involved in?
I
Is it
don't.
metabolic?
So I can find out for you. So lifestyle metformin can mitigate some of the genetic risk for development of diabetes. Okay, now what about, so this is in a research setting. What about, is there any way we could translate this to the community? Well, several people have done that. They've taken our diabetes prevention program and actually just on their own instituted it in the lifestyle. So they adapt the lifestyle sessions, a 12-week session, implement it in the community. They see significant decreases in weight circumference, and BMI. And after about 3 months, the average of weight loss was 7.4 pounds. So you can see most people lost, some weight. The blue bars were weight loss of about 3.5%, red bars weight loss of over 5%, and the green bars weight loss of over 7%. So most people lost weight. This is another study called the Deploy Pilot study, and this was in a high-risk population. So they took people who had high cardiovascular risk, and they gave them this in a YMCA type of setting. And again, what they found was that what you could do over up to 12 months' time, if you did the DPP intervention, which is the purplish bar, they actually lost weight, and they were lower, and their total cholesterol went down, their blood pressures went down, they had a lower rate of development diabetes. This is just total cholesterol results. So if you did DPP for 4 months, that's the green bar. If you did DPP for 12 to 14 months, that's the purple bar. And that's compared to the placebo groups above. Other studies have shown the same thing. What you can do is you can get weight loss, reduce glucose, and reduce progression to diabetes. And the final bullet I think is really important. We treat medicine today like it's still acute care, like people are still getting gunshot wounds and they need to go to surgery, or they're getting an acute infection and a 6-day course of antibiotics will treat it. But we're in a totally chronic care world, so we have to figure out a totally different way of taking care of people. We've got to stop this whole thought about, you know, the 20-minute encounter or the RVUs or something. It's a chronic care world that we still treat like it's an acute issue. And Los Angeles County has a diabetes prevention program. Tony's not here, but Tony's in charge of this. And this is something Tony put out last year. Diabetes and prediabetes screening guidelines and expansion of the National Diabetes Prevention Program in Los Angeles County. So we have access to that right here at home.
And I'll just mention that Tony Quo is going to be speaking here on September 20th, so we can hear more about it then.
So
Sorry.
that was another key lesson. It's feasible to translate the DPP into the community. Now, the last part I just want to talk about, we got to be smarter about who we target to therapy, because there's some it's like high-risk patients that are like the elephant in the living room that we kind of don't necessarily look at. If you get gestational diabetes, it used to be something that we'd say, that's just while you're pregnant. Oh, good. As soon as you get done with pregnancy, it'll go away, you'll be fine. But we know now that's not true. So if you have gestational diabetes, you're likely going to get diabetes in the future. It's not 100%, but it's a much higher percentage. And what you can see is for different race ethnicities, no matter what they are, after about 5 years after they deliver, these are young women, so, by age like 35, about 60% have already developed diabetes. So this is a high-risk population. You've got to target interventions to them. If you were born at a low birth weight, that's someone we probably should target interventions to as well. I think the best data is probably from the Nurses' Health Study here in the middle. If you had a very low birth weight, your odds ratio of developing type 2 diabetes in the future is about 3. If you have a high birth weight, your odds ratio is about 1.5. So either too low, which is worse than being too high, you have an increased risk of developing diabetes in the future. And if you have abnormal glucose tolerance, we know you're at risk for developing diabetes. So it turns out the worst is if you have both impaired fasting glucose and impaired glucose tolerance, so a high postprandial and high fasting. But even if you only have impaired fasting glucose on one occasion, that's it. There's about a 7.5-fold risk of developing type 2 diabetes in the future. So a lot of times people, go to the doctor, their fasting glucose is high, the doctor calls them all alarmed, and they're like, I'm gonna get serious about this. I'm not gonna eat sugars anymore, I'm gonna do everything right, and they come back and it's normal, and they're like, dodged a bullet. Well, this is someone that's still gonna be at really high risk. And again, if you have both together, that's the highest risk of all.
So Carol, one of the things that a lot of people complain about is that testing blood sugar is not part of the normal physical exam on a regular basis.
It is for most doctors in the Kim panel, we get it. They should, most of us do it, I think. So these are some of the risk factors for developing type 2. Advancing age, family history, history of gestational diabetes, obesity or abnormal fat distribution, here in the middle, decreased physical activity, very low birth weight, certain medications like antipsychotic medications or antiretroviral medication, HIV medications. So we really have to get smart about targeting interventions to our most at-risk patients. It'd be great if we could do it to everyone in a cost-neutral world, we would, but given that cost is a consideration, we have to figure out how to target these interventions. Oh, okay, and the final thing is, we live in a very obesogenic society. It's really, like, I can't even tell you how, and I don't know, we've given mixed messages to patients. So we would have these meetings with our DPP participants where we talk about, it's important to get these fruits and vegetables in, and they'd be like, I've done such a great job of getting my fruits and vegetables in. I've been to Jamba Juice every day this week. Tell them that. Okay, that's not exactly what I mean. Like, we have to figure out how to get the right portion size and get the right foods into us. So you look at portion sizes and how they've exploded, and so like the typical Starbucks coffee I call a breakfast milkshake, because that's really what it is. The typical muffin I call a breakfast cupcake, because that's really what it is. And the size of the salads is greatly, and even all the things that they say, well, all I eat is salad every day, but it's like a claim jumper salad. But portion sizes, as we know, have gone up for everything: salty snacks, desserts, soft drinks. So we live in a really obesogenic society. You have to consciously fight against it to not gain weight. And this is not from DPP at all, but this was a study done by my classmate at Harvard, Nick Christakis. So he found that many biobehavioral things we do can be spread in social networks, just like infectious diseases. So he basically found that if your spouse gets obese, you're like 10 times as likely to get obese. If your neighbor next door gets obese, you're like 5 times as likely. If your best friend, you're like 3 times. So basically, what we learned at DPP was you cannot just give this education to the participant. So we would have a lot of family events because everyone has to buy into this in order for our participant to have success. So that's the last thing I'm saying. It really does take a message. Everyone has to be working to the same goal to get this to happen. Oh, and the last thing Chloe asked me to put in, she said, how can we prevent people on statins from getting diabetes? Well, I want to convince you that statins don't cause diabetes at all. So, it was 30 years of statin availability before we realized actually there was some association between being on a statin and development of diabetes. And we didn't know that until the Jupiter trial. The Jupiter trial was a randomized controlled trial where individuals with high CRP, which is inflammation, but normal LDL cholesterol were given a statin, rosuvastatin, or placebo, and then followed up what was supposed to be 5 years. It was prematurely terminated because there was so much benefit in reduction of atherosclerotic disease in the group that got the statin. But one of the things they saw, which was surprising, was an increase in physician-diagnosed diabetes in that group. And so everybody said, well, that's crazy, where did that come from? But then they went back and looked at other statins and saw, oh, look, I guess it's over several statins. So we say, well, there's rosuvastatin, atorvastatin, and simvastatin. Pravastatin is sort of neutral, and lovastatin may not be, but we don't know. We see it overall. Overall there's a 1.09 odds ratio. But in the Jupiter trial, when they looked closer, they say, if you got into that trial and had no major risk factors for diabetes, you had nothing. Then if you're on rosuvastatin or placebo, it didn't really matter. So there were 86 deaths or vascular events prevented, no excess cases of diabetes at all. But it turns out when you enroll a population via CRP, which is an inflammatory marker, you inadvertently actually select for a high prediabetes group. They didn't try to do that, but it turns out they did. So if you got into this study and you did have major risk factors for diabetes, metabolic syndrome, impaired fasting glucose, high hemoglobin A1C, or elevated BMI, then that's where all the excess cases of diabetes happen. So there were still 134 deaths or vascular events prevented, but 54 excess cases of diabetes. And if you look at other trials where they looked at that, up top shows the incident diabetes in the Prove-It trial, A to Z trial, TNT, IDEAL, or SEARCH, and there is an increased risk have diagnosed diabetes. But if you look down below at those exact same trials, there's also a reduction in events. So when you look overall, the risk-benefit ratio definitely favors treating, because the number needed to treat to avoid one event, 155 patients. The number needed to harm to cause one case of diabetes, almost 500. So I tell my fellows all the time, statins don't cause diabetes. They unmask the diabetes that was inevitably going to happen anyway to that patient, and it actually allows them to get on life-saving therapy. So, in conclusion, now about 18 million people with diabetes in the USA, and even more with prediabetes. Lifetime risk is really high, about at least a third for men and women, and for certain race ethnic groups like Hispanics or South Asians, it's going to be even higher. In this population, cardiovascular disease is a major cause of death, so preventing diabetes and cardiovascular disease is crucial. Thank you very much for your Yes.
I have two questions. One is the contact that you mentioned with the touching patients, especially with the lifestyle modification. Back in 2002, there probably wasn't a lot of social media kind of things happening back then, but now there are. Have you incorporated any of that, or do you think it's really the in-person kind of touching?
Great question. Interestingly, no, we have not at all. And if you look at our population, particularly in Los Angeles, it's a lower socioeconomic group and an older group now, 13 years later. Many of them don't even have a computer or use it, so it's all still either personal contact via phone or coming in to a clinic visit or meeting at a restaurant where you have a group.
The second question then has to do with the weight loss issue, which was clearly significant. And you touched a little bit on it in some of the later studies, the issue of waist circumference. So if you look at weight versus, do I have a waist circumference issue, or do I just have a weight issue that's not sort of focused on that body organ? Do you think that that might be a targeting point to?
So that's a good question. I've always felt that waist circumference was more important, but we couldn't find that in our DPP study, probably because everyone had big waist circumference. It was too hard to find people who didn't. The only ones that didn't were the South Asians that we had, who actually looked pretty lean, but we know that they have a lot more visceral fat than we know. So we couldn't tease it out with that, but I'm still a firm believer in weight circumference.
Thank you.
So this is a great talk. Thank you so much. I have two questions.
Could you just say who you are? It just helps for us to all get to know each other. Hi, Tracy.
Absolutely. Hi, I'm Tracy Emily from Kaiser Permanente. So my first question is, when I was looking at your graph of weight loss versus metformin, and I guess the sustained weight loss, the metformin from my non-research eyes looked equivalent to weight loss. So I'm curious your thoughts on that. And then but you clearly were promoting weight loss, and I was curious if the metformin arm showed some other, I don't know, adverse outcome or anything.
No, okay, that's a good question. I was trying to highlight in the talk. Again, I'm a huge lifestyle believer, but I am acknowledging that over time, metformin looks just as good. And if you, so I didn't show you this, but if you look at in the DPP OS forward period, the trajectories of development of diabetes are exactly the same in the lifestyle and the metformin group. So we actually we just got refunded for phase 3 of DPP-OS, and it's all about metformin and trying to tease out some of the pleiotropy. So we're looking at cancer reduction, we're looking at, metformin is just looking better and better. But again, I'm a huge lifestyle believer. I'm trying not to treat everyone with a drug.
Have you studied DPP and metformin?
So that's honestly what actually the metformin group now is.
Oh,
Because
okay.
remember, in the period between DPP and DPPOS, we offered everyone lifestyle. And now, lifestyle is just such a part of everybody's thing. So the metformin group now really